Greetings from sunny Stockholm, Sweden. It's an honor to share some minutes with you colleagues on an update on the STHLM3 MRI trial. I will focus on some lessons from the second screening round in this trial that might influence how we implement and perform future studies on prostate cancer screening. My name is Tobias Nordstrom. I'm a clinical urologist here at Danderyd Hospital, Stockholm, Sweden, and am the PI for the STHLM3 MRI trial performed at Karolinska Institutet. Here are my conflicts of interest. I will start by giving a short overview of the STHLM3 MRI trial, which uses a combined paired and randomized design with men coming in having 2 blood tests, and if any of those are elevated, they are randomized to a traditional arm with systematic biopsies or an experimental arm with MRI and targeted plus systematic biopsies. We have almost 13,000 participants with a 26% participation rate using the STHLM3 test, which is a combination of clinical protein and genetic markers, a short protocol, biparametric MRI, and centralized MRI and pathology. We presented the results from the first screening round almost 2 years ago, showing that targeted plus systematic biopsies performed in MRI positive men have a non-inferior detection of significant prostate cancer defined as Gleason score 7 or more, as compared with performing traditional systematic biopsies in all. And equally important, we also see that the detection of low-grade tumors defined as Gleason score 6 is much lower in the MRI arm, where 4% of men randomized to the MRI arm had a Gleason score 6 detected, as compared with 12% in the traditional arm. We have then also shown that the STHLM3 test, a novel blood test including clinical protein and genetic markers, outperformed PSA, which is similar to previous studies, but in this prospective setting it was well calibrated and decreased the need of MRI by about a third in the first screening round. We also showed that in lifelong prospective modeling studies, both PSA and MRI and STHLM3 and MRI were health economically reasonably attractive in the Swedish system, but maybe more important, the use of modern risk stratification, such as the STHLM3 blood test, might decrease the need of MRI by 60% when taking repeat screening settings into considerations. We had some criticism for the STHLM3 MRI trial when it was published, while the disease verification differed between the study arms. So we employed targeted biopsies in the experimental arm. But excluding the targeted biopsy results from the primary analysis, we see that even if we only count the systematic biopsy results from the first screening round, we still capture the majority of the traditionally detected significant cancers. So this is quite astonishing that despite 62% of MRIs being negative, and those men did not need a biopsy, we still detect the majority of the traditionally detected Gleason score 7 or more cancers when employing systematic biopsies only in the MRI positive men. So this is no longer non-inferior, but it still says that MRI is a powerful tool to select the correct men for biopsy. So we have now moved on and performed the second screening round, where we see that we have a higher participation rate than in the first screening round, with 72% of invited men actually coming for testing. And we also have a high compliance when coming to testing for the recommended interventions. So I will share some preliminary findings from the repeat screening rounds and discuss a few lessons that might be taken into considerations when designing screening implementation and future studies. So first we see that the PSA level of individual men varies between the first and second screening round, and this might be very intuitive and just as expected. Looking at this from another perspective, we see that men coming in with a PSA between 1.5 and 2.9, in 30% of the cases, these men will have an elevated PSA of 3 or more at the repeat screening round. And there's also a movement in the other way towards lower risk categories. But in summary, 45% of men coming in for repeat prostate cancer screening in this trial setting have an elevated PSA and thus an indication for performing a prostate MRI. When then having this MRI, we see that many MRIs are negative. In the first screening round, that's 2/3 of MRI performed lacked suspicious lesions. But in the second screening round, this is even higher, with 80% of performed MRIs in the second screening round were lacking suspicious lesions, defined as PIRADS score 3 or more. However, if having a suspicious lesion, the distribution of biopsy findings, they seem to remain relatively stable between the first and second screening round, with about 40% of men with a PIRADS 3 having a significant cancer, moving up to 80% and over 90% of men with PIRADS 4 and 5 having a significant cancer detected on the biopsies. So to summarize the findings in repeat screening using PSA and MRI in prostate cancer screening, we see that the participation rate is much higher than in the first screening round, in our case 72%. We also see that almost 40% of men coming for repeat screening will have an MRI, and the majority of those MRIs will be negative. However, if having a lesion on the MRI, the predictive value of that seems to be stable between the first and second screening rounds. About 5% of men coming into repeat screening will have a prostate biopsy, and about half of the biopsy procedures are positive for significant cancer, defined as Gleason code 7 or more. However, the cancer detection is limited, which might be positive for the detection of non-significant disease, while 0.8% of the participants in the repeat screening setting had a Gleason score 6 detected. On the other hand, it might also be a limitation, while only 0.7% of the participants had a significant cancer detected when employing more stringent definitions such as Gleason score 4 plus 3 or more. So to conclude this, we see that in the rescreening setting, when doing modern prostate cancer screening with PSA and MRI, it's common with reclassification based on the blood tests. And we also see that we risk to have very high volumes of MRIs performed in the rescreening setting, where more than 40% have an indication for MRI. We also see that there is a high proportion of negative MRIs, with almost 80% of MRIs performed with lacking suspicious lesions. And there is a limited detection of significant cancer. So we suggest that using improved risk stratification, such as the Stockholm 3 test or the 4K score or the 5 score, might decrease the number of MRIs substantially in our own modeling studies, up to 60%. We also suggest that de-escalated screening interventions should be studied in the upcoming time. And Stockholm 3 MRI will provide knowledge on both blood test performance, health economy, screening intervals and interventions, and we're now prospectively collecting the third screening round, where we also include men with an original PSA below 1.5. So I just want to highlight the immense work done by a large number of people to perform this trial, and I'm so grateful also for the national funders for the Stockholm 3 MRI trial. And with this I say thank you for your attention. I'll be happy to discuss this and other results in the upcoming discussion setting. Thank you so much.